So I'm here to, talk about how we manage arrhythmias today. And, things have changed significantly in the last 20 years. So I think it's nice to be able to, give everybody an update on how we do things. All right. So usually we like to start with, a patient presentation, try to give an example of the kind of patients we see every day. So here's a 50-year-old patient, a male, with increasing fatigue, shortness of breath over the last few weeks, no other symptoms. And he's overweight and he presents with an irregular heartbeat and some mild lower extremity edema or swelling. This is what his EKG looks like, and you can see it's very irregular and fast. And this is what atrial fibrillation looks like. This is a new diagnosis of atrial fibrillation. And so the question is, what do you do? And there's a lot of options, but the first thing is you want to make sure this patient doesn't have a stroke. And so we want to start anticoagulation or a blood thinner based on their stroke risk. And some common options are Eliquis or Xarelto or Coumadin. Also, you want to make sure their heart rate doesn't go too fast, and we might put them on a medicine like a beta blocker or a calcium channel blocker to keep the heart rate under control. And then oftentimes we want to consult a cardiologist or cardiac electrophysiologist to get their opinion on what to do next, as it's usually a cardiologist that'll be managing this patient in the future. And then also, you want to see what you can do to try to prevent this AFib from coming back in the future by addressing other risk factors, looking to see if the patient has sleep apnea. So we would order a sleep study or get an echo of the heart and make sure there's no structural issues or valve issues in the heart that could be causing this AFib. Some people get a stress test based on other risk factors. Maybe they have coronary disease. Obesity is a common cause of AFib, and patients may need a weight loss regimen. So atrial fibrillation is a fast, irregular atrial arrhythmia, usually coming from what are called the pulmonary veins, and it's associated with an increased risk of stroke. There's different types of AFib depending on how often the patient is in it. Paroxysmal is the earliest onset of AFib. It means it comes and goes, and each episode usually doesn't last more than 7 days. There's also persistent AFib, which lasts more than 7 days or requires something called a cardioversion to shock you out of it, or a medication to convert you into normal rhythm. There's also something called long-standing persistent AFib, which is atrial fibrillation that's continuous for more than a year, and permanent AFib. And the only difference between long-standing persistent and permanent AFib is if we're going to do anything about the AFib, if there's still a plan to get that patient back into normal rhythm. If there's no plan, then we say it's permanent AFib. And we talked about some of the causes of it. As you get older, coronary disease, hypertension, sleep apnea, valve disease. Sometimes people are just genetically predisposed to have AFib at an early age, or sometimes it's alcohol abuse and things like that. And AFib is very common. It affects greater than 6 million Americans. Over 750,000 hospitalizations every year are due to AFib. And there's a common procedure we do for AFib now called ablation. But if we ablated every patient with AFib, each doc would have to do 37 of these ablation procedures per week, which just isn't possible. And there is definitely a need for AFib treatment, as there's a large and growing patient population, especially in the underserved patient population areas. You can see here, there's a 33 million estimated global prevalence, and this is probably a lower number than reality. And more than 60% of patients have symptoms associated with their AFib. And 31% of patients with AFib have one or more hospitalizations per year. And by 2035, you're going to have double the number of AFib patients that you have today. So the way we treat AFib has also changed over time. In the past, there was a trial called the AFFIRM trial that came out in 2002 that showed that people live just as long whether they're in AFib or in sinus rhythm or normal rhythm. And all they would say is just control the heart rate and then keep them on a blood thinner. And that's what a lot of the older cardiologists did. They didn't put much more importance on AFib. As long as the heart rate was under control, that was it. But now we've seen multiple trials since then showing that there is a lot of benefit to being in normal rhythm over atrial fibrillation, especially in patients with any kind of weakened heart muscle called cardiomyopathy or CHF. And over time, ablation has become more and more safe and faster procedure to the point where it's a 2-hour outpatient procedure. And it's now considered a first-line therapy for AFib in many patients. And AFib is progressive. And what happens is, early AFib, we know where it comes from. It comes from the pulmonary veins. But as you can see, as time goes on, you develop more what's called cardiac remodeling of the tissue, the left atrium. It becomes more fibrosed, and this yellow kind of in this graph represents that. So the more AFib you have, the more triggers for AFib develop over time. So the best time to intervene on AFib is when it's considered paroxysmal, early episodes of AFib when it comes and goes. The more AFib you have, then you're going to have other trigger points and other ablations that are needed to get all of the potential triggers causing it. So people may need multiple ablations to get rid of it. And so there are consequences of AFib continuing on without any treatment. And there's decreased quality of life. 20% of patients, there's a 20% higher risk of stroke with AFib compared to normal sinus rhythm, even when they're on blood thinners. There's a 28% higher risk of death in patients with AFib compared to normal rhythm. And this is people who are on blood thinners. There's twice the prevalence of heart failure. There's 1.5 times higher increased risk of hospitalization for cardiovascular problems, and then 6.5 times higher risk of stroke. And there is data here. This is from 2019, showing that a shorter diagnosis to ablation time is associated with lower arrhythmia recurrence and also reduced cardiovascular hospitalization. And this is kind of the basis for why some other hospitals might be forming what's called an AFib clinic or atrial fibrillation clinic. The idea is that if somebody comes into the emergency room with AFib, they're immediately hooked up with a cardiac electrophysiologist who can do an ablation to reduce that time of diagnosis to ablation. And you can see here, the longer you wait to get, let me go backwards. The longer you wait to get an ablation, the longer the success rate long-term is. And this is looking at less than 1 year. Ideally, a patient could get ablated within a month or two of their diagnosis, and the success rate should be even better. So decreasing that time from diagnosis to ablation is an important factor. And there's a lot of now new updates in our guidelines that offer AFib ablation as a potential first-line therapy for management. In the past, they used to say, well, try medications first, and if the medications fail, then you can be considered for AFib ablation. But now with all the data coming out showing that there is benefits with ablation even beyond anti-arrhythmic drugs, that now they say, okay, patients can be considered for ablation as a first-line therapy. Multiple trials came out in 2021 showing a certain type of ablation called a cryoablation, where we freeze around what are called the pulmonary veins to get rid of those trigger points causing AFib. And all of these trials showed that cryoablation was superior to medications in preventing AFib long term. So this was looking at recurrence of arrhythmias over 12 months. The blue line is cryoablation. The red line is antiarrhythmic drugs. And as you can see, ablation was superior as far as freedom from arrhythmias in the 1 year period. There are also some quality of life and symptoms that were looked at, both, again, showing that cryoablation was superior to an antiarrhythmic drug. There are some complications that can occur with ablation, but they're very low. And we say it's less than 1% for a serious complication like stroke or heart attack. And as you can see in these trials, stroke or death or fistula, which can also lead to death, all of those were 0%. 1% risk of myocardial infarction, 1% risk of pericardial effusion, which is fluid that can build up around the heart. And then that 1.9% of what's called phrenic nerve involvement, which usually resolves on its own, within a month. This is kind of what it looks like. As you can see, this is the left atrium, and these are these veins that have muscular tissue around them that can get hyperactive, and the signals come from the veins and trigger the heart and put it into AFib. So the idea is we want to create scar tissue around these veins so the signals don't come from the veins and go to the heart, and you got rid of the trigger points of AFib. And with the cryo balloon, the balloon goes into the heart, inflates, we place it up against the vein, and it starts freezing. And it creates scar tissue around the vein. And within 30 seconds, often, we'll see those abnormal signals as measured on this catheter disappear within 30 seconds. And this is what it looks like under X-ray while we're freezing. Some more benefits of this method of ablation is that these patients are discharged home the same day after 2 hours bed rest. The actual time we're ablating in the left atrium is usually about 30 to 40 minutes. They'll usually follow up with me in 2 to 4 weeks. I tend to keep the patient on blood thinners for about 6 months, depending on their stroke risk. And at the 3-month mark, if they're on an antiarrhythmic drug, I'll usually stop it if there's no recurrence of AFib. At the 6-month mark, if they have a low stroke risk, I will consider stopping their blood thinner long term. So the majority of my patients I see in clinic are for atrial fibrillation. And as long as there aren't any contraindications, ablation therapy is offered as a viable initial option to treat AFib. And other options include medical management versus what we used to do, which is control the heart rate and just put them on the blood thinner. But as we've already gone over, recent data shows these options to be less effective. With newer technology, such as cryoballoon, ablation is very safe and efficient, but it's not the only aspect of treatment. There are also other risk factor modifications that have to occur, such as losing weight, looking to see if you have sleep apnea, treating blood pressure, all of those things. A last resort type of management for AFib, when all else fails, or if patients are very sick and can't undergo a risky procedure of some kind, then we can sometimes we'll do something called an AV node ablation. We find the electrical connection between the top and bottom chambers of the heart. While the top chambers are in AFib going fast, we're sending all those signals down the AV node to the ventricle. And so if we ablate the AV node, then the top and bottom chambers no longer communicate with each other, and the bottom chambers are very slow on their own. So if we ablate the AV node, that means they have to have a pacemaker placed as well. And the pacemaker will pace them at a normal rate. So if you feel your pulse, it feels normal, even though the top chambers are in AFib. And so it does work very well, but it's usually for people who can't tolerate an AFib ablation, or for some reason are just too sick to do something more common like that. And they would still require anticoagulation because the top chambers of the heart are still in AFib and clots can still form. But doing the AV node ablation and pacemaker, very low risk procedure, very easy to do. And here's a review of how we score patients to see how risky they are for stroke. This is called the CHADS-VAS score. And you get a point for congestive heart failure or LV dysfunction, hypertension, age. If you're over 75, you get 2 points. If you're between 65 and 75, you get 1 point. Diabetes, history of stroke, you get 2 points. Any vascular disease, such as coronary disease or vascular disease in your legs or carotid artery disease, and if you're female. Usually, if you have a score of 2 or higher, you need to be on a blood thinner. Now, this is a picture of the heart under ultrasound, and this is called the left atrial appendage. This huge blob in the left atrial appendage is called a thrombus. This is a clot that forms in the heart when you're in AFib, because when you're in AFib, the top chambers are no longer actively contracting and pushing that blood forward. Blood can just sit in this pocket here called the appendage and turn into a clot. This is what breaks off and turns into a stroke. So if you have a CHADS-VAS score of 2 or greater, you should start a blood thinner, which are usually Eliquis, Xarelto, or Coumadin. And if you can't be on a blood thinner because of multiple reasons, you should consider what's called Watchman. Now, a Watchman device, this device has actually been in trials for the last 15 years, but it's now readily available in all hospitals to be done. And it's actually a very quick and relatively low risk procedure. It takes about 30 minutes to put one in. So just through a vein in the leg, we place a catheter up to this appendage, and we place this device that opens up and it blocks off the appendage. And your own tissue eventually grows over the appendage. But by having this blocking off the appendage, so clots can't form here and break off and go to the brain, this is equivalent to being on a blood thinner to prevent stroke. So it's a great thing to have this available because now patients who can't be on a blood thinner to prevent stroke have another option to protect them. So it's an alternative to long-term blood thinners. If patients are tolerating their blood thinner fine, then we usually don't need to put a Watchman in. But there are examples, as you can see down here. If you have a history of a GI bleed, it may not be a good idea to stay on a blood thinner long-term, or a history of a brain bleed. Or if you fall or have an unsteady gait, right? We have a lot of older patients who might need walkers or feel unsteady. And if they fall and hit their head and they're on a blood thinner, that's high risk for a brain bleed. People who are on dialysis or have end-stage renal disease or kidney disease, they tend to have a higher bleeding risk. And they also qualify for Watchman. Lifestyle kind of means if people have a very active lifestyle and can't do what they usually do because of the blood thinner, such as playing sports or mountain climbing or something like that, then they can also be considered for Watchman. Patients who are non-compliant or who might have some dementia and forget to take their Coumadin often, or have a difficult to control Coumadin with their therapeutic level going all over the place, or if they're already on multiple other blood thinners for history of coronary disease and they have a stent, maybe being on 3 different blood thinners might be too much. You could consider Watchman to get you off of one of them. Okay. Other common arrhythmias that we see are SVT. And SVT, it just means a very fast but regular rhythm. And there's different types of SVT. It's kind of an umbrella term. And you don't have to memorize these, but there's AV-NRT, or called AV nodal reentry tachycardia. There's something called Wolff-Parkinson-White syndrome, which also is called AV reentry tachycardia or atrial tachycardia. These are all kind of, more detailed for a cardiac electrophysiologist to know the difference, but the bottom line is that they all look pretty similar on EKG when you present to the emergency room. And there's also atrial flutter, which could be typical atrial flutter or atypical flutter. And the common thing with all of these arrhythmias is that ablation is how you fix it. Ablation is first-line therapy. Medications rarely work well to control any of these. So if any of these arrhythmias are diagnosed, they're supposed to be referred for ablation per the current guidelines. Other common arrhythmias that may not require ablation first, frequent PVCs or extra beats that come from the bottom chamber of the heart, or dangerous arrhythmias in the bottom chamber of the heart that could race and may lead to cardiac arrest. Usually we try medications, but if medications don't work, or if there are a lot of these PVCs, then we could do ablation for that as well. Other ways that we manage ventricular tachycardia, which is a fast rhythm from the bottom chamber of the heart, is to protect you from dying from cardiac arrest. And that means putting a defibrillator in. So patients with cardiomyopathy or very weakened heart muscle with an ejection fraction less than or equal to 35%, or if they have evidence of that dangerous rhythm, ventricular tachycardia or ventricular fibrillation, those patients meet criteria for a defibrillator. Because if you have that ventricular tachycardia or ventricular fibrillation at home, that would mean your heart's beating really fast at home, over 200, 300 beats per minute, and that would make you pass out. And if someone's there, they will call 911, and by the time the ambulance gets to your house, that might be 20 minutes of no blood flow to your brain, and that might be too late. If you have a defibrillator, the device which is implanted underneath the skin here, with leads going through the vein to the heart muscle, this device can charge up and shock you out of it within 10 seconds. Or while it's charging up, it can also try to pace you out of it to prevent a shock. And so defibrillators, more than any medicine or any therapy that's available, have been found to save more lives with patients with cardiomyopathy or ventricular fibrillation than anything else. There are other conditions that also require, or where a defibrillator or ICD can be considered. There's cardiac sarcoidosis, which is more prevalent in the African American population, but it involves scar tissue developing in the ventricle. Some forms of what's called long QT syndrome, which is a genetic predisposition to these dangerous arrhythmias. Or some medications can cause that too. There's also a genetic, it's called a channelopathy that can cause something called Brugada syndrome. These are all things that tend to have an EKG pattern that we look at. And if we see that EKG pattern, sometimes we have to call the cardiac electrophysiologist to look into it to see if this is concerning and you might need a defibrillator. There are two kinds of defibrillators. This is the traditional defibrillator that involves wires being implanted through the vein, all under X-ray camera. It's placed in the heart muscle, and it's attached to a generator that will sit underneath the skin below the left clavicle. For patients who don't have good IV access, for example, dialysis patients, or patients who are very young who maybe we don't want to place a lead into their heart muscle at such a young age, the alternative option is the subcutaneous ICD, where we place the ICD deep under the tissue here, below the armpit, and we tunnel a lead underneath the skin in the chest. And all of this is outside of the chest cavity. It's just all underneath the skin. So it carries with it a much lower risk of infection, and these leads and device can be taken out at any time. Versus over here, the leads are implanted inside the body, in the veins, directly into the heart. If any of these leads have issues, it's a more of a process to get these wires out, and maybe a higher risk procedure. Now, we also have pacemakers, which is for people who are symptomatic with slow heart rates, which could be due to sick sinus syndrome or AV block, or if you have something called tachybrady syndrome, where your baseline heart rate is slow, maybe 40s or 50, and you also have these fast heart rates that need to be controlled with the beta blocker, which would slow your heart rate even more. So you're kind of stuck between a rock and a hard place. You usually get a pacemaker, so your heart rate will never go too slow, and you can be put on the correct medicine. So this is on the left here is a traditional pacemaker. Here's the device. And again, leads, just like a defibrillator, are implanted in the same way. one to the top chamber, one to the bottom chamber. And you attach the battery component, all that sits underneath the skin over the muscle. And it's just a small incision right here that you see at the end. We do have a newer type of pacemaker that some patients may qualify for called a leadless pacemaker, where just through a vein in the leg, we can implant a bullet-shaped device into the ventricle of the heart. And this is the entire pacemaker. There's no leads going up here, no extra battery. The whole thing is right here. And this is for people who would need pacing just in one chamber of the heart, who don't need to be paced in the top chamber of the heart. Although there is a newer leadless pacemaker that will be coming out at the end of the year and maybe early next year, where we can implant one of these little devices in the top chamber too, and they communicate with each other through Bluetooth. So this is called a leadless pacemaker. And there are some patients where this is a better option, especially if there's higher infection risk. These tend to be lower risk of infection. Patients who have difficult access issues, or they're just very elderly or very thin. You're worried about what's called a pneumothorax. You can just place that device very easily through the vein in the leg and leave it there. So lead extraction is another thing that, at least at Methodist Hospital, we're going to start doing. Although implanted leads are supposed to be permanent, they may still be removed for certain indications. Infection, particularly a bacteria called Staphylococcus, that tends to really be aggressive and stick onto those pacemaker leads, and they won't clear the blood until we remove that pacemaker. Sometimes leads fracture or malfunction. Some patients need an MRI, and they may have an older pacemaker lead that's not MRI safe. We need to take that out. Lead extraction can be performed either with a laser or with a mechanical rotating dilator sheath. And as you can see, this is what it looks like when you take the lead out. There's scar tissue all over the lead. The longer the leads are in place, scar tissue develops around them. And when you take it out, you see these areas of scar tissue that's binding lead to the vein. The laser sheath, if we put that over the device, there's an actual laser inside the sheath, and it vaporizes the scar tissue off of the lead as it pulls through. So another future technology that's coming out is called pulse field ablation. And this will be a huge change in how ablation for AFib will be performed in the future. Because of its safety, it only affects cardiac myocytes. So that means when we're ablating the tissue in the heart, it's not going to affect the nerves around it. It shouldn't affect the esophagus. All those areas will be safe. And the ablation time is seconds. It takes 3 seconds to apply a single lesion of ablations or ablation lesion at that spot. So it works very well. And that technology will be available next year. And Methodist will actually hopefully be the first hospital in Northwest Indiana to obtain this technology to provide the safest and state-of-the-art care for our patients here. So this is what the PFA or pulse field ablation catheter looks like. This one in particular is made by Medtronic, but there's another one that will be made by Boston Scientific that looks similar. We place that vein again, place the catheter again up against that vein, and instead of freezing, it just sends a signal and it immediately creates scar tissue within 3 seconds of a lesion. So it's very effective, and the whole EP community is very excited about this, as this is what most people are going to switch to when they do their ablations for atrial fibrillation. So in conclusion, early referral to EP or cardiac EP will improve patient outcomes, especially with atrial fibrillation. Ablation therapy is a safe procedure that should be considered first-line therapy for most patients with AFib. Watchman implantation is a great option for those patients who are poor candidates for long-term blood thinner. State-of-the-art pacemaker and ICD therapies are here and available at Methodist right now. Lead extraction program will be started very soon with cardiac EP and CV surgery. And future technologies such as pulsed field ablation will come next year and make Methodist a leader in the region for AFib management. Thank you, and let me know if you have any questions.
Can you hear me?
Yes.
My name is Stacy, and I'm a 58-year-old female.
Hi, Stacy.
Hi, and I was really glad to see this was available for online education.
Sure.
Because I had about 3 years ago, I had bariatric surgery. I just had the sleeve done at that time, and I had some issues with my heart with some, different beatings. So I was recommended to see a cardiologist, which I've been going to for 3 years now.
Right.
I've had, I had my test and everything done. And the only thing that I don't, listening to you and symptoms and things that I don't feel like I'm being informed as I should be for the information that you've given me. Okay. So I wrote down some things. So I'm to see my cardiologist on the 24th, and just knowing what type of questions to ask, because I was told that I had like an extra beat, and I also wear a smartwatch, and sometimes my heart rate drops below 60. Okay. And sometimes it's up like 100, so it fluctuates, but it's not often all the time. And then sometimes I'm lying in bed and I can feel the difference in my heart beating. So with that, just saying that, is that possibly where I'm at? And then I was also told that sometime long down the line, I'll probably have to have a pacemaker.
Oh.
Yeah.
Well, I don't know about that. The heart rate suddenly dropping like that, but you not having any, big differences in how you feel could be how that your smartwatch is measuring your pulse.
Okay.
You're having a lot of those extra beats, which could be PVCs, is what I'm guessing.
Mm-hmm.
We often see that it won't count those PVCs as part of your heart rate, and it looks like your heart rate's half of what it really is.
Okay. So anyway, I've had like the echo done, and that's when I was told that I have an extra heartbeat. But at this time, I'm not on any medication. I am able to exercise, and I haven't really, I don't have, like any major symptoms or anything. But like I said, sometimes I'm lying in bed, I can feel the difference in my heart, the way it beats.
Have you worn a monitor to count the number of beats that you're having?
I have worn a monitor, yes.
Did they tell you what percentage you're having of extra beats?
No, that's what I'm saying. Some things are not, as far as questions or as far as answers given to me, I'm just told that whatever the issue is, but not what's actually happening. I'm feeling real uninformed. So now I'm sorry, go ahead.
No worries. So one thing you should probably just ask is, exactly what is your diagnosis?
Okay.
Is it PVCs? Because you want to get the name of what you have right. Because just saying extra beats, sometimes that can confuse. Like if you go for a second opinion, they won't know exactly what you had.
Okay, I appreciate that. Yes.
So diagnosis, and then just let them know you're symptomatic from these beats, and you don't feel like you're getting anything to treat it. They may start you on a medicine to try to control it.
Okay.
Or they might say, see the cardiac EP to talk about ablation to get rid of it.
Okay. All right. Sounds good. And something told me I needed to come on to this call when it was, when the pamphlet came, I said, you need to get on there and see what's going on. But like I said, I do have a cardiologist, but I just want to know, I want to be more informed, about what's happening, because just telling me those things is not enough, because it's something pertaining to whatever's happening to me.
I think it's also important to know that some of the older cardiologists, right, that might have practiced the way it was 20 years ago, they may be less quick to refer you to an EP to do a procedure.
Okay.
Because they thought, okay, well, I've treated this, for 40 years. We just put people on this medicine and they do fine. But there are a lot more options now as far as how to treat it.
Okay.
So I don't know who your cardiologist is. Don't say the name.
I'm not in the medical field myself, so
we do have a lot of options to how to treat these arrhythmias now. It's not always just you'll be fine, don't worry about it, or just take this medicine. There's not much else we can do. For pretty much any arrhythmia, we're going to have 4 or 5 different options on how to treat it.
Okay, I will get more in depth. I have an appointment on the 24th, so I will spend some time there and get more in depth into what my issues are. Yes.
Sure. Okay. Thank you.
I thank you for your answers.
No problem. Are there any other questions?
Hello?
Yes.
Can you hear me? I'm on a medication of ATENOLOL. What is that? Atenol?
It's a tenolol. It's a beta blocker. It treats blood pressure and slows the heart rate down.
Okay. Yes, I would have, heartbeat fast sometimes. Okay. So is that connecting with anything with AFib?
Some people use it to treat AFib, just to slow the heart rate down. It doesn't get rid of the AFib.
Okay.
So it's more to help with symptoms, but it's not getting rid of the AFib.
Okay. So this is AFib I could possibly be on if he's got me on this. Is that what you're saying?
Right. I mean, he should tell you why you're on the medicine. Some people just take it for blood pressure too.
Okay, no, this is not for blood pressure. Years ago, I think he said something about PCVs. I don't know, but I'll have to go and check and see. I don't want to say it.
So PDCs are these extra beats in the bottom chamber of the heart. And sometimes we actually can ablate that if people are very symptomatic, or if you wear a monitor and it shows that you're having more than 10% of your beats are PVCs, we usually just do the ablation to get rid of them.
Okay.
But
So
if they're infrequent, if it's like less than 10%, like 2% or 1% PVCs, then it's reasonable to try a medicine to control it.
Okay, yeah, because if I don't take this, then I will get fast heartbeat. Okay. And so is this in danger of a stroke or something like that, would you say?
Not PVCs, but atrial fibrillation and atrial flutter both have a high risk of stroke, but not the other arrhythmias.
Okay, all right. Thank you so much.
No problem.
Does menopause have anything to do with when your heart is beating differently?
It's a great question. I don't know if I'm the expert to answer that, but yes, I mean, any kind of hormonal changes seems to affect, frequencies of arrhythmias. Whether for good and for bad. I've seen it both ways.
Okay. Thank you.
Well, thank you for your time. I'm glad you did this.
Oh, no
it was
problem.
Very helpful.
All right. Anything else I can answer or any other questions?
Not on my end.
Okay.
I'm also good. Thank you so much.
Oh, no problem. Thanks for everyone for joining, and I'm around.
Could you put up the
Thank you.
Could you put
Thank
the
you
slide
everyone
up
for
with your
joining.